Great. Should I start?
One second. Good morning. Today is my pleasure to introduce Dr. Moti GUlersen. He's going to present us today ground rounds in the update in the management of chronic hypertension in pregnancy. Dr. GUlersen did medical school at the Roth and Bruce Rappaport Faculty of Medicine and Technion Israel Institute of Technology. His residency at the Lenox Hill Hospital in New York and fellowship at North Shore Long Island Jewish Hospital in Long Island. And we also have a welcome guest, Dr. Rochilson, our mentor. Welcome, Moti, and thank you so much for this update in the management of hypertension.
Thank you very much. Thanks so much for having me. It's an honor. I'm very excited about this. As Dr. Roman mentioned, today we're going to be talking about updates in the management of chronic hypertension in pregnancy, and kind of give some more information regarding a guideline that we're working on in terms of adjusting to the literature that's been published in the past year. So no financial or conflicts of interest to disclose, but I just wanted to say I've loved my time here so far. So thanks for everyone who's been so supportive. So in terms of chronic hypertension, we want to remember that it's defined as hypertension with a systolic blood pressure greater than or equal to 140 or diastolic blood pressure greater than or equal to 90 or both that's diagnosed or present before pregnancy or before 20 weeks of gestation. And just remember, again, we use kind of that similar 4 hours, at least 4 hours apart cutoff like we do for any other hypertensive disorder of pregnancy. I think also what's really important to remember is that, proper blood pressure measurement is important. Usually, you want to take a blood pressure after 10 minutes of rest, being seated, back and arm supported with uncrossed legs and appropriate cuff size. And often in our outpatient setting, that's not always true, as we have patients kind of being rushed into their rooms and have blood pressure checks soon after. So just be mindful of how to take a proper blood pressure measurement. The prevalence is about 2% in the US, and it continues to increase due to the increasing rates of pregnancy among patients who are obese and of advanced maternal age. And as also we know, chronic hypertension disproportionately affects Black women. Now, I put an asterisk next to the definition of hypertension because, as we know, the American College of Cardiology and the American Heart Association had provided updates in their diagnosis of hypertension in patients who were not pregnant back in 2018 to include that actually stage 1 hypertension is based on a systolic blood pressure between 130 and 139 or diastolic blood pressure between 80 to 89. So just remember, we haven't necessarily changed our management or definitions in the pregnant patients, but it's important to note there's been a lot of evolving research in this area, as we know that the diagnosis of hypertension is different in non-pregnant individuals. So why do we care about chronic hypertension in pregnancy? Clearly, there are a lot of maternal and fetal and neonatal risks. We think about obviously the most common risk of superimposed preeclampsia, which can occur up to 50% of patients with chronic hypertension. And then we always counsel patients regarding the risks of end organ damage like stroke, pulmonary edema, renal insufficiency, myocardial infarction. Obviously, there is an increased risk of maternal death as well. Cesarean delivery, postpartum hemorrhage, gestational diabetes. And then, of course, we see a number of fetal and neonatal risks like fetal growth restriction, preterm birth, and stillbirth. So obviously very important, condition, highly prevalent that we deal with and has a lot of associated risks. Now, in terms of treatment, antihypertensive therapy is really the standard of care for non-pregnant patients. Again, we have these guidelines regarding, management of non-pregnant individuals with hypertension. Most of the time, treatment is based on blood pressure with an associated cardiovascular disease risk that you can calculate over 10%, within a 10-year time period. And usually, standard of care has been, especially for those 140 over 90, initiating antihypertensive therapy, even initiating it in 130 over 80 with some increased cardiovascular disease risk. And the evidence is very clear on management of hypertension in non-pregnant individuals. But really, treatment in pregnancy has, there's been kind of limited evidence up until recently regarding, what's the optimal way to treat hypertension in pregnancy. And there's really been a number of a wide variation in international guidelines in how to manage hypertension in pregnancy. What's clear is that, when you do have severe hypertension, which is, diagnosed based on systolic blood pressure greater than or equal to 160 over 110, we on labor and delivery, there's been a general consensus supporting treatment to reduce the associated risk. But I think what's important to remember is, the data is really not strong. In terms of treating severe hypertension, it's really been indirect from treatment of preeclampsia or extrapolated from guidelines of non-pregnant adults. It seems rather unethical to potentially do a randomized control trial of patients with severe hypertension because that's an increased risk of stroke. So we'll never really have level 1 evidence in chronic hypertension in pregnancy, but just I think it's important to remember severe range hypertension, the data is not very strong in terms of treatment. All that's been extrapolated based on patients with preeclampsia or who are not pregnant. And then in terms of mild hypertension, which, again, just based on the defined criteria, as we see here, based on systolic blood pressure or diastolic blood pressure greater than 140/90. Again, we haven't, there's still some variation in management of that. A lot of the, initial data came from a Cochrane meta-analysis looking at about 58 trials with about, small studies, a total of almost 6,000 patients, which show that treatment of mild to moderate hypertension, which was defined in this meta-analysis of studies, including one up to systolic blood pressure 140 to actually 169, reduced the risk of severe hypertension without any difference in preeclampsia, preterm birth, fetal growth restriction, or fetal death. So, again, historically, we're saying, okay, there's maybe a marginal improvement in the risk of severe hypertension without an improvement in potentially risk of stroke and organ damage, although you need a lot of patients to show such a significant difference in a rare outcome. And there's really no benefit in improving perinatal outcomes like preeclampsia, preterm birth, fetal growth restriction. So again, historically, we were thinking, is it even, is there any benefit to treating mild hypertension? Furthermore, there was also that concern. I think there's, a lot of people who have trained, historically, there was that really concern about not only is treatment of antihypertensive with mild range blood pressures potentially not going to improve perinatal outcomes, it might be harmful. And that was based on potentially this meta-analysis that demonstrated that there, a greater mean difference in mean arterial blood pressure was associated with a higher proportion of small for gestational age infants. Again, that physiological impact of interrupting or decreasing uterine blood flow, I think, has really been a long-standing concern amongst, senior physicians and obstetricians in terms of, the concerns regarding treatment of antihypertension. So really, based on these two meta-analyses, we were thinking, okay, yes, you might reduce the risk of severe hypertension, not really improving prenatal outcomes, perinatal outcomes, and really potentially causing harm in terms of, increased risk of just small for gestational age infants. So again, very clear that there was a lot of that there needed to be large randomized trials focusing on this population exclusively. So that's when, the CHIPS trial was first published in 2015. This was published in New England Journal of Medicine, less tight versus tight control of hypertension and pregnancy. A humongous effort, multi-center trial with the primary principal investigator coming from Canada, Laura McGee. So I'm going to go into, again, this paper. This was an international multi-center randomized controlled trial, which took place between 2009 to 2012. Inclusion criteria were singleton pregnancies between the gestational ages of 14 to 33 and 6. So just be mindful again of the gestational age. And this included patients who had non-severe, non-proteinuric pre-existing or gestational hypertension. So just remember that this wasn't an exclusively chronic hypertension population. And I think just important to note that the diagnosis was based on diastolic blood pressure alone, basically greater than or equal to 90. There was no inclusion criteria of hypertension based on systolic blood pressure. And the randomization, was two groups, basically doing tight control, which was based on a target diastolic blood pressure of less than 85, again, something we're not really familiar with, versus less tight control, which was, a target diastolic blood pressure of less than 100. So again, just be mindful and understanding of the inclusion criteria, the randomization, and target blood pressures for this trial. Labetalol was the first drug of choice, and the primary outcome was a composite of pregnancy loss, composite like we always see in these large randomized trials. It included miscarriage, ectopic, termination of pregnancy, stillbirth, neonatal death, or higher level of neonatal care for 48 hours, the 28 days, or until discharge home. And then a lot of secondary outcomes included serious maternal complications that we talk about in terms of uncontrolled hypertension, eclampsia, any of the end organ damage, stroke, et cetera, myocardial infarction, and death. So of note, when we're thinking about the baseline characteristics between the two groups, just something to note is the race ethnicity is not reported in this trial. And then remember that up to 25% of the patients included were ones that had gestational hypertension and not chronic hypertension by definition. So just be mindful of that. Several patients also, were on antihypertensive medication at enrollment, and not many were, a third of the patient's population were nulliparous. Again, always important to look at, baseline characteristics like, for example, obesity. Our population is for the most part obese. That these patients, up to 50% were obese. So in terms of the primary outcome, there was no significant difference, in the primary outcome between less tight control versus tight control. In terms of the adverse perinatal outcome that we mentioned, there's a composite. Again, as a safety measure and things we always think about in terms of small for gestational age babies, birth weights, with no difference between the two groups. So providing some evidence that actually potentially even this may not be a harmful intervention for patients. But again, question of whether or not there's benefit based, especially based on this trial. When they looked at secondary outcomes in terms of serious maternal complications, no difference between the two groups. But of note here, as you see with severe hypertension with tight control, there was a significant reduction in the rate of severe hypertension, which again makes sense. You're using an antihypertensive medication, you're going to have lower blood pressure and lower likelihood of developing severe hypertension in those groups. So that was noted. But of course, when you look at the outcomes related to potentially having severe hypertension, like these uncontrolled or end organ damage type picture, we wouldn't see any significant difference in serious maternal complications. But just be mindful, of course, that you need significant numbers, and these are underpowered, to show differences in these particular outcomes. So limitations with the CHIPS trial is that, over 50% of patients in each group were already on antihypertensive therapy at randomization. Only a third of the patients were enrolled at less than 21 weeks of gestation, which we think about, chronic hypertension by definition. And then, of course, there was limited power to evaluate some outcomes potentially influenced by treatment. Again, this is probably the first large randomized trial to provide evidence on management of, hypertension in pregnancy. A humongous effort, provided some good data for us. But, as this was, emerging, the United States kind of got ahead, and the NICHD, had presented the idea and opportunity for an MFMU trial. And that's what was published last year that we're all kind of familiar with in terms of the CHAP trial. So kind of another large randomized humongous effort from the United States, looking specifically at mild chronic hypertension during pregnancy. And the rationale is, again, focusing exclusively on this patient population and potentially utilizing different types of cutoffs for control that we're more familiar with in terms of diagnoses, et cetera. So a lot of names here that you're probably all familiar with. Alan Tito was the principal investigator at Alabama. This was very much a landmark trial in our field. So again, multi-center, in the United States, randomized controlled trial between 2015 and 2021. The inclusion criteria were singleton gestations less than 23 weeks with chronic hypertension by the definitions that we're familiar with. Blood pressure, mild range, 140/90 or above, less than 160/105, actually, which I'll get into that in a second, and greater than 4 hours apart, or taken ambulatory in the office. And the randomization was based on, instead of less tight versus tight control, they used active treatment with a target blood pressure goal of less than 140/90 versus standard treatment, which was essentially withholding treatment unless severe hypertension develops, which again is what we as providers have been most familiar with in terms of the management of these patients. So for this trial, labetalol or nifedipine XL was preferred. Again, medications that we're familiar with in the hospital and outpatient setting. The primary outcome here, though, is a little bit different than the CHIPS trial, which was now focusing mainly on preeclampsia with severe features and medically indicated preterm birth less than 35 weeks with a combination of abruption or fetal or neonatal death. So this was a primary composite outcome. It was evaluated in several subgroups based on hypertension treatment status at baseline, race, ethnicity, the presence of diabetes, BMI, gestational age, and enrollment. These were planned subgroup analysis. So again, important, we'll get into that as well. And then, of course, similar to the CHIPS trial, secondary outcomes included composite maternal death or serious complications, like we think about stroke, et cetera. And then also composite of serious neonatal complications. And here with this trial, again, in terms of data safety monitoring, which we do often for large randomized trials, is that they had a safety outcome based on SGA to again determine it along the way was, active treatment causing any harm during the study period, and that outcome was SGA. So when we look at the baseline characteristics, we see that almost 50% of patients were non-Hispanic Black, and over 50% of patients were diagnosed and receiving medication prior to entering into the trial. And a large part of the, again, in contrast to the CHIPS trial, over 40% of patients have been randomized less than 14 weeks were at the gestational age of less than 14 weeks. Again, mean body index was, greater than 37, which kind of seems more applicable to kind of the patient population that we kind of deal with here in Philadelphia. So this to me, seems like a very much focusing on chronic hypertension, probably the most commonly encountered scenario here, early diagnosis in the pregnancy, and then kind of similar baseline characteristics to what we see here in Philadelphia. So when they looked at the differences in systolic and diastolic blood pressures throughout the trial, there was significant differences in the actual measurements of blood pressure compared between the two groups. And if you look here, you're saying to yourself, okay, systolic blood pressure was 129 versus 132. Okay, that's significantly different, but is that clinically significant? 3 millimeters of mercury difference in blood pressure? We're talking about 143 versus 140. Well, apparently, in non-pregnant patients, even such a small difference in blood pressure has improvement in cardiovascular outcomes. So I think that was like the first thing, I thought about when I'm looking at this graph. Again, marginal differences, 2 millimeters of mercury diastolic, 3 millimeters of mercury systolic. But apparently these differences can be clinically relevant in patients even who are not pregnant. So again, important to know that. So active treatment group, lower blood pressure throughout the trial and when after randomization. And then when looking at primary outcome, which, again, included the composite of preeclampsia, medically indicated preterm birth, placental abruption, or fetal neonatal death less than 28 days, there was a significant difference, significant reduction in the risk of this primary composite outcome with active treatment. And when you look at the four components, it's really the preeclampsia with severe features and medically indicated preterm birth that were significantly lower in the active treatment group, to 23% versus 29 and 12 versus 16. And we'll kind of get to what does that mean? And then, of course, the safety outcome in terms of, small for gestational age, less than 10th or less than 5th percentile, no significant difference between the groups. So again, important to know, clearly this trial demonstrating benefit in terms of adverse pregnancy outcomes with no increased risk in small for gestational age. Again, kind of trumping that historical context of, does active treatment reduce blood flow and cause, growth restriction in small for gestational age fetuses. Then they looked at all these subgroup analysis, and I think made note of that even newly diagnosed, which we potentially may encounter no difference when you look at that subgroup specifically, or even in the BMI greater than 40, which we commonly encounter here in Philadelphia. But again, just important to remember that these subgroups, the sample size becomes smaller, the power becomes insufficient to make these types of conclusions. So clearly, these two populations potentially warrant more investigation. And notice that regardless of whether you had diabetes or gestational age at entry, nevertheless, that active treatment was significant. So again, important to know, and it's unique to look at these subgroups. And then when we think about, again, the secondary outcomes like serious maternal adverse events, like composite cardiovascular complications, again, look, you're seeing very small numbers, so unlikely to see any significant difference, but maybe a 0.7% reduction in some of these variables might be clinically significant. But again, the authors are stating no significant difference between the two groups. Severe hypertension, clearly a significant reduction with active treatment, which again, makes sense. And then going back to what I had mentioned with the figure, the difference in blood pressures by millimeters of mercury were significant, and actually even a difference of 3 and 2 with systolic and diastolic, again, just to reiterate, can actually be clinically significant in the non-pregnant world, and that's been demonstrated. So again, I think important. When we look at the composite severe neonatal complications, no significant difference. Again, small numbers, these are rare outcomes, so underpowered to detect significant differences. And then when we think about preterm birth, of course, we did see that there was a significant difference in preterm birth, not only less than 35 weeks, but also less than 37 weeks, as well as birth weight and less than 2,500 grams. No difference in NICU. And again, here are all these other secondary outcomes that we saw that they looked at. So again, just to kind of state the conclusions of the CHAP trial, again, landmark trial, treatment of mild hyperchronic hypertension in pregnancy to a goal of less than 140/90, improves maternal and neonatal outcomes without really negatively impacting fetal growth. And the number needed to treat to prevent that primary outcome was about 14 to 15, which is very small, which is good. Just of note, aspirin use was equal between the two groups and increased based after randomization, but they didn't see that influenced the primary outcome. So again, really humongous effort. This is a large trial with very significant conclusions and clinically relevant. Of course, like any randomized trial, we think about limitations. There was a screen to randomized ratio of 12:1, which may have limited the generalizability, but just important to remember that even in light of that, characteristics of screened and enrolled patients were similar between the two groups, and most patients were excluded due to gestational age requirement or had blood pressure below entry requirements, despite the diagnosis of chronic hypertension. And I think it's, again, remember that historically we think about pregnancy physiology, the peak NATE around 16 to 18 weeks of blood pressure goes down. So again, you may have potentially uncovered, you may have missed the opportunity to enroll patients because of the criteria based on that. And then again, something I talk about, when I talk about in clinic with the fellows and residents, et cetera, just be mindful that home blood pressure measurements were not incorporated to study eligibility. Again, they wanted to do a pragmatic trial. Not everyone's compliant with taking blood pressures at home. So just be mindful of that. Of course, we encourage our patients to check their blood pressures at home, and we get a lot of good information from that. But just remember, a lot of these trials, didn't include 100% of these. Like the CHAP trial didn't have any home blood pressure measurements, and the CHIPS trial wasn't even complete in terms of patients checking their blood pressure at home. Another, limitation that we've talked about. I even had this conversation with Dr. Rogerson when I presented this, this update back in fellowship. Is again, if you think about the primary outcome of preeclampsia with severe features, which alone now, based on our new definitions, can be just severe hypertension that's uncontrolled. It seems kind of tautologic. You're giving a medication, you're actively treating a patient with their blood pressure. So of course you're going to have a lower incidence of preeclampsia with severe features, if especially the criteria for the diagnosis is related to blood pressure. So then as a result, if you have less diagnosis of preeclampsia, and after 34 weeks, if you have severe hypertension, you're going to deliver. Something that's always warranted discussion, I brought up on Twitter, et cetera, is that, okay, active treatment is going to be, it just makes sense. If you're actively treating their blood pressure and that severe hypertension is required for the diagnosis of severe preeclampsia, then obviously the rate of severe preeclampsia is going to be lower in the active treatment group. So I think, again, something to think about, I thought it was interesting because this trial took place between 2015 and 2021, and we knew that over time, the diagnosis of preeclampsia, we went from severe preeclampsia to preeclampsia with severe features using just severe hypertension alone as a criteria. So, so I think it's just worth, and I'd welcome any comments about that, in the discussion. So then, of course, after such a large trial, SMFM came out and basically released the statement and reviewed the CHIPS trial, reviewed the findings of the CHAP trial, and basically came up with the conclusion that we should be treating patients with mild chronic hypertension in pregnancy to a goal blood pressure of less than 140/90 because of the benefit in reducing adverse pregnancy outcomes, which includes preeclampsia with severe features and medically indicated preterm birth less than 35 weeks without increase in harm in terms of like the safety outcome like SGA. So I think that this was, SMFM responded very quickly and appropriately. And so that's kind of why we're talking about today, because, we're going to be trying to implement these types of findings to our institution. Future considerations, again, what about patients with mild chronic hypertension or with with chronic hypertension who present with mild range pressures after 23 weeks. That's a patient population that we should think about, and we'll talk about that. What about the impact of treatment to target, the American Cardiology College versus the Heart Association goals of blood pressure less than 130/80? In fact, the number one abstract going to be presented at SMFM this year is a secondary analysis of the CHAP trial looking at this patient population specifically, and they actually found some interesting findings, which I won't spoil now, but I'm very excited for that. And then, looking at the impact of treatment in newly diagnosed hypertension or BMI less than 40, like those two subgroups that I mentioned, in terms of whether or not that'll be effective. And then, of course, like anything we think about in obstetrics, what are the long-term outcomes associated with these types of interventions? So what should we do now? Here at Jefferrrrson, we were communicating at one of the meetings, I think it was a couple months ago, and I think some of the team were of the general OB/GYN the practitioners were commenting on, okay, how should we treat this? We should develop a guideline, and we agreed. So we kind of worked together to come up with some sort of guideline to update the management of chronic hypertension in pregnancy in line with the recommendations that were made by SMFM and ACOG. So I kind of wanted to go over, what are some of the possible clinical scenarios that you'll encounter in the outpatient setting, or even less likely in the inpatient setting. So first, you may have a patient with self-reported diagnosis of chronic hypertension without any evidence of previous hypertension in the medical record and not taking any antihypertensive. We commonly see this. Their first blood pressure at their visit is like 120/60. They're telling you, oh, my doctor told me that I had a high blood pressure. You don't see it anywhere in the medical record. Perhaps that blood pressure diagnosis may have been made based on stage 1 criteria for AHA. So I think for the purposes, we're going to treat those as chronic hypertension. So that's one clinical scenario that you may encounter. Another clinical scenario you may encounter is that a patient has a diagnosis of chronic hypertension with evidence of previous hypertension in the medical record and not taking antihypertensives. So we get relieved, we see in the medical record, and I always encourage the fellows, residents, students, et cetera, to look at, just go back to visits. Like, I know we have in EPIC, it's hard to see vital signs specifically, but go back to as many visits as you can. It becomes a little bit challenging in the emergency room because, again, how are they taking their blood pressure? If they're in pain, they have a reason, that can be difficult, but just look at outpatient visits. You see hypertension prior to pregnancy. Okay, we're safe. That's a diagnosis, et cetera. A third encounter you may have is the diagnosis of chronic hypertension who's taking antihypertensives. Again, straightforward, simple. We know we see those patients a lot. And then the last possible clinical scenario is you have a patient without the diagnosis and they present with one-time elevated blood pressure before 20 weeks. So for those patients, again, you're seeing new onset hypertension prior to 20 weeks in pregnancy. Again, those patients are you going to want to confirm the diagnosis, whether it's greater than 4 hours apart or at the next visit, or initiate them on ambulatory blood pressure monitoring. So these are kind of the possible clinical, and there may have been another potentially that I might have missed, but we can welcome that in discussion. But there's a lot of different clinical scenarios. But for the purposes, all of these patients, even after the confirmation of diagnosis in number 4, are going to be treated as chronic hypertension, and that includes patients that come to you and tell you, my doctor told me I have hypertension. Might have been stage 1. You might have seen in the medical record is 121/81. For the purposes, and I think ACOG even supports that, and we discuss it as a division. Let's include those patients as those with chronic hypertension. So what do you do if you have mild chronic hypertension less than 23 weeks of gestation? Well, first you're going to confirm the diagnosis. And then we decided and discussed that, home blood pressure measurements can be utilized as long as there's one elevated blood pressure is documented in the outpatient setting, and there is appropriate documentation regarding similarity of home blood pressure measurements with office blood pressure measurements. Because again, we often encounter scenarios where patients are coming, they are, let's say the blood pressure is 121/80 in the office, but they're telling you it's 160/110 at home. Again, it can differ based on cuff size. It can differ where on the arm they're taking it. What is, the blood pressure cuff? So I think calibration is important, and documentation is really important for these clinical scenarios. And the recommendation for these patients, similar to what we saw in the CHAP trial, is antihypertensive therapy for mild chronic hypertension in pregnancy to a goal blood pressure of less than 140/90. Again, familiarizing ourselves with the first-line medications like we know about labetalol, extended release, nifedipine. And I think what's also important here is that if you see this scenario and you already are on one medication, you want to up titrate that one medication to a maximum dose as tolerated by patient before adding a second medication. So mild chronic hypertension less than 23 weeks, initiate or increase antihypertensive therapy to a goal of less than 140/90, and up titrate one if possible before adding a second. You don't want to have someone on labetalol 200 BID and then start them on nifedipine 30. Just not effective, it's not efficient. We have up to 2,400 milligrams of, labetalol that we can use. I mean, I know it sounds scary, but early in the pregnancy, we can titrate and go accordingly. So which patients are eligible? So again, this is important in these, this will be outlined more specifically in the guideline, but, we felt that both singletons and multiple gestations should be included, even though multiple gestations have always been excluded from these randomized trials. And we actually have no idea whether or not targeting blood pressure in these patients is effective. Again, just, the mild range hypertension. And I wrote here diastolic of 90 to 109, because often in trials, the diastolic for what's considered treatment of mild range, or, it was up to 105. The 105 to 109 have often been excluded. And, the CHAP trial cited that potentially there might have been provider bias because there's a lot of those patients actually get treated. So they use up to 105 to maintain consistency amongst those. But we're going to be consistent with just what mild range hypertension is and use up to 109. If they're taking 1 or 0 or 1 antihypertensive medications, I think if you're, again, on 2 medications, which is, not encountered so commonly, again, you have to be careful with those patients. So 0 or 1, and those were excluded from the CHAP trial. No evidence of class D or higher pregestational diabetes. And those are patients who, let's say, have diagnosed at an age less than 10 years old, or had diabetes for more than 20 years, or have any signs of end organ damage, retinopathy, renal disease, cardiac, etc. So we want to make sure that those patients, those are not necessarily eligible for this, and then we think about no evidence of chronic kidney disease based on baseline proteinuria, which is, again, the criteria that we're common with. 24-hour greater than 300, protein creatinine ratio of 0.3, urinalysis greater than 1 on-spot protein, or creatinine of greater than 1.2, and that was just based on the CHAP trial. And then, of course, unfortunately, we see in our patient population here in Philadelphia, patients who are actively using cocaine or methamphetamine. These are patients that are, that can be the reason why they're presenting with higher blood pressure. So those, you got to treat those patients, those wouldn't necessarily be eligible, or any current withdrawal related to substance use, because we encounter hypertension in those patients as well. So that's again, mild chronic hypertension, less than 23 weeks. We know the recommendation, we know the patients that are eligible, so let's be mindful of that. But what do you do about mild chronic hypertension greater than 23 weeks? And in those patients, this cannot be new onset hypertension, because if you have new onset hypertension greater than 23 weeks, we know the diagnosis is gestational hypertension, not necessarily chronic hypertension. And based on the findings of the CHIPS trial, right, well, those patients weren't even found to have any significant benefit. And we're focused exclusively on chronic hypertension here. So the recommendation would be then to rule out superimposed preeclampsia, which we often know, how to do, assess for symptoms, do blood pressure monitoring, see if there's any severe range blood pressures, or look for any preeclampsia lab, abnormalities, including proteinuria. Because if you have an increase in proteinuria, then of course you make the diagnosis and you have to treat those patients a little bit differently. And we decided to say, consider antihypertensive therapy to a goal blood pressure of less than 140/90, utilizing shared decision-making. And the reason is because we don't have level 1 evidence to support that this is an effective intervention at this gestational age, but it can be considered. I even tweeted about this, and Alan Tita, the principal investigator for the CHAP trial, responded saying, for these patients, I would treat them. And so I think we want to be, we want to treat to a goal blood pressure, but I think once you're getting after 23 weeks, you got to really make sure that you're ruling out superimposed preeclampsia. When we're thinking about up-titrating medications, you want to up-titrate one to a maximum dose, similar to what we talked about with less than 23 weeks, but just be mindful, again, if you have rapid increases in blood pressure, rapid increase in the need for an antihypertensive medication for these patients, you should be concerned about preeclampsia, which again is really, really difficult to make as a diagnosis. Even those who have severe hypertension, we commonly encounter this. Severe hypertension alone, we know that it's a diagnostic criteria for superimposed preeclampsia, but if in a chronic hypertension, that might be an exacerbation. It's a kind of a gestalt type picture, maybe individualized when we get into those types of scenarios. But here with these patients, we said, what, consider antihypertensive therapy, utilize shared decision making, because there's really two reasonable alternatives. You can say no, or you can say yes, and it's both associated with no significant harm that we know of. Again, those eligible patients would be the same as previously described, and of course, no evidence of superimposed preeclampsia, which, again, when we think about presence of symptoms, persistent severe hypertension, those are severe features, but proteinuria isn't. So again, if you have a patient who had a baseline PC of 0.1 and now they're 0.4, still do a 24-hour urine to confirm that diagnosis, because that's a gold standard for the diagnosis. Those patients necessarily wouldn't be eligible, or at least you have to have a discussion with the patient. I think, again, with these patients, documentation is essential. As I have always talked about this with fellows, residents, et cetera, please document thoroughly regarding what your suspected clinical diagnosis is and what's the rationale for or against antihypertensive treatment. Because this helps, again, if a patient is coming to the triage or the hospital, looking at the documentation for us as providers, understanding why medication may have been treated, what's the suspected diagnosis, or even if they're evaluated in the hospital. I've always been an advocate of this. Documentation is really essential for these patients. And then if you have, let's say, mild chronic hypertension greater than or equal to 34 weeks, again, emphasizing that this cannot be new onset hypertension. You have to have documentation of a previous diagnosis or previous elevated blood pressure early on in pregnancy. Again, whether we see this, it's going to be potentially less often because we're going to be actively managing patients earlier with medication, but we can encounter the scenario. We want to, again, rule out superimposed preeclampsia, and as a division, or we decided that, or we are offering that actually not initiating antihypertensives because we're already at a gestational age that we have to be really concerned about preeclampsia nearing timing of delivery, and so I think that can really potentially cloud the diagnosis and mask potentially preeclampsia. So that would be for the for chronic hypertension greater than or equal to 34 weeks. And just to remind, what are antenatal surveillance guidelines for patients with chronic hypertension on antihypertensive medications? Our guidelines support the use of weekly non-stress tests starting at 32 weeks and serial fetal growth ultrasound every 4 weeks starting at 28 weeks. This is different than patients who are not on antihypertensive medications who get one growth at 32 weeks and do NST starting at 36 weeks. So again, just you can always ask us or whatnot, send us a message. What are the guidelines once you are making the new diagnosis? And we're happy to help. So yeah, I think that's a lot of information. I think again, I guess I went through things a little bit more quickly than anticipated. But again, I want to thank you for having me, and I welcome a discussion about clinical scenarios from any of the guests or audience on, and we can talk about it. Thank you.
Hi, Moti. This was a great update. Thank you very much. I dropped a question in the chat there.
Oh, let me take a look. Sorry.
Yeah. I can also just say what I wrote, which was like a lot of patients where we find elevated BPs in the first or the early second trimester, and they don't have a prior diagnosis of chronic hypertension, they're incredibly resistant to just the label of chronic hypertension. And we end up spending a lot of time just talking with them and trying to explain to them why it matters and why we care and that it's important. And now if we're going to be more aggressive with treatments and having lower treatment guidelines, we're now faced with not only trying to get people to believe they have this diagnosis that they don't want, but trying to convince them to get on medications for it potentially. And I was just wondering if you have thoughts about how to best engage those patients and how to do those discussions, or how to reconcile how we should be documenting, because when we have a guideline that says these people should be getting treatment, we start thinking about making sure we're documenting like what we're counseling and what we are, what we're recommending and what patients are declining a little bit more carefully than some of our sometimes like frankly slapdash like visit documentation at OB visits.
Yeah. So I'll be honest, I think that's been one of the challenges that I've had in general since coming to Philadelphia with the patient population, not only with hypertension, also diabetes, right? We have patients with an A1C that's elevated, criteria for diabetes. They don't believe they have the diagnosis. They look at their sugars, they're fine. Or you have this like scenario that you say, office BPs are elevated, home blood, they check their blood pressure at home, it's normal. They don't think that they have a diagnosis. I honestly, I maybe someone else can potentially comment on the best way because I'm still learning on how to tackle these types of patients. I try my best to say to first make sure that the diagnosis is, because yes, there's white coat hypertension that we have, but even those patients, there's evidence to say up to 40% of those patients will develop preeclampsia. So I don't know if that's maybe the specific type of patient you may be mentioning, like someone who has elevated blood pressure. Sorry, go ahead. Someone gonna say something.
Hi, Moti. Thank you, Rebecca, for saying that. I have been in the same situation as you have been with patients that are extremely resistant to the diagnosis. They don't want to be labeled high risk and having more visits and more antenatal testing and earlier inductions. I think the only way is just continue seeing them, continue communicating, continue incrementing her visits to continue the discussion. I do the home blood pressure checks in a way to know how do they behave at home, and just continue talking and convincing them that at least they'll come to the antenatal testing, more NSTs, more ultrasounds, more growth ultrasounds, to be sure they have a good outcome. That's the way I do it in clinic. But yeah, that's a major problem. And also we're working with the MPH students to look at the personal beliefs and personal views of medical conditions on different medical conditions. So there are several MPH students who are going to start surveying patients in clinic and on the phone to ask them, what do you think about your disease, and what are your views on your diagnosis and your management?
I think also with patients with hypertension, again, it's like they say like it's a silent killer. They feel fine. They don't necessarily believe. Or I've often encountered patients that they come right into like they're running around to get to the appointment. They sit down and right away the blood pressure is taken. And I mentioned the emphasis of proper blood pressure measurement. And those are the ones that are not going to believe they have the diagnosis. So I think repeating blood pressure, counseling, and I guess at the end of the day, really documentation, I think is really, really important. But at least, reiterating the fact that hypertension is dangerous and making sure that, again, it's an appropriately taken blood pressure, doing our best to just counsel. But I'm still struggling with that.
And engaging the providers. I think, Moti, it was actually a friend of yours that was a pediatrician ours that couldn't believe that she had hypertension, if you recall, and I sent her for an ultrasound. I think I sent her to MFM, and I believe she developed preeclampsia, but it took a while, and different providers hearing the same thing from different providers.
Yeah,
I think another thing that can help is, like Moti had said a lot, and I think sometimes we use the word without thinking what it means, but shared decision making. It's not, I think that's the most important thing, and just acknowledging the uncertainty. So, it's true, they can have a mistaken blood pressure. They could have had a blood pressure taken at the wrong time. And I think helping, build those like building blocks of evidence for the patient, that you're not basing it just on one time when they ran in. Okay, you feel like you were hurried, let's just pause and take it again. Here's a blood pressure cuff, log it at home, bring your blood pressure cuff in with you, let's compare it in the office. And I think maintaining, like, I completely agree with what Amanda said. It's just maintaining that constant communication, not kind of mentioning it once and then dropping it because she declines the diagnosis and that's the end. And I think also bringing in personal experience, like, do you know anyone with hypertension? Does anyone in your family have hypertension? And then relating it to, that diagnosis, it is a silent killer. So often there is this experience in the family of someone with hypertension who all of a sudden got very sick. So yeah, I think that's kind of the approach. It does add time to the visit. It does add counseling. And, I think it's also fine for someone with an uncertain diagnosis to have an MFM consult for, like someone mentioned, like having different people saying the same idea. A lot of times the first time someone hears something that's different from what they think, the immediate reaction is to reject it, and it does take time.
Moti, I would like that we revisit the diagnosis of superimposed preeclampsia and the management.
Sure. What do you mean? Like in terms of
Like in one of your slides when you said if there is superimposed preeclampsia, not to manage, not to increase the medication. Is that what I hear?
No, I was just, this is just for mild chronic hypertension when superimposed preeclampsia is ruled out. This is not, I didn't present kind of management recommendations based on the diagnosis. That becomes obviously much more, complicated. We know it's a higher risk. They need frequent monitoring. It's I think a little bit different.
Yeah, and just to remember, the ACOG recommendations for diagnosis of superimposed preeclampsia is a patient who was diagnosed with chronic hypertension with or without medications, whose blood pressure start going into the severe range and require either initiation of medications or escalation of medications. That is one of the criteria of superimposed preeclampsia.
Yeah, I
It's
think
still the delivery is 37, but that immediately triggers weekly anesthesia, weekly blood work.
so. I think again, I think we talked about this. I think one of the most challenging diagnoses, and I think it's even talked about in the practice bulletin, is how do you know potentially if it's an exacerbation of chronic hypertension versus superimposed preeclampsia if you're looking at just hypertension alone. Because, again, you might have, and this is usually when you encounter these triage patients with a one-time severe, whether they're on medications or not, you increase their medication and everything is fine over several days. And I don't know, I feel like those are really challenging, and we often find a difficulty in management of those patients.
Moti, there was,
And-
yeah, go ahead, Amanda.
Just one last suggestion, like in these kind of situations when you have one severe blood pressures and you don't know what to do, I think I'll encourage you all to admit the patient 24 hours. There is nothing wrong with that. We need more information. We need more blood pressures, maybe 2 sets of lab work and more anesthesia before saying you don't have superimposed preeclampsia.
Moti, again, great presentation, such an interesting, important, controversial topic, great discussion. I want to bring you back. I'm actually going to share my screen. The CHAP trial surely is changing in the world, and it's really an important one. But as usual, there is always a lot of, I don't know if you could see my screen, a lot of previous information. This is the Cochrane from just a few years ago on antipersentate drug therapy for mild to moderate hypertension. They actually included 58 trials, almost 6,000 women. And like you showed, I think severe hypertension, it's always going to be decreased. Every trial you looked at, and this Cochrane showed that. So it's nice to look at consistency of the data. What's different with CHAP is that preeclampsia is decreased. But if you see in this meta-analysis, there was a trend for decrease, and there was a trend for decrease for preterm birth as well. So, when you put it together, and I don't have to spend too much time on that, the novelty is the CHAP trial was larger than trials before, was US, was very much like you said, Philadelphia, population, and that those trends for preeclampsia and preterm birth became significant. And that's where I think what moved, the whole field as MFM, because around the world, really, because of that Cochrane, this is not done. But I do agree that, this better data deserve attention and a change in practice. So thank you again for doing this. Another my comment, if I have a second, is, you excluded bad diabetes and kidney disease, with creatinine of 1.2 or more, because of the trials and because of everything else. Obviously, those may be people who are most at risk of developing preeclampsia, of developing preterm birth, of developing, complications in general. So I know there is no data, and I think I'm fine with the guideline being like that. But on the other side, if somebody has 156 over, 95, and has a creatinine of 1.4, maybe she's the one who may need more hypertensive med than another one.
Yeah, definitely. I mean, I think, yeah, like you mentioned, those patients have up to 75% risk of developing supraimposed preeclampsia. I just think that like for those patients, they're complex, depending on the gestational age. Often actually patients who are not pregnant or that, we think about those with end organ damage are actually even have a lower threshold for the treatment of antihypertensive. And I think, yeah, we can even add to that for those patients and say, consult with our cardiology, nephrology colleagues and work to reduce the, try and improve blood pressure.
Wonderfully done. Thank you so much.
Any other, I think I'm just looking at the chat for patients stating it.
There's not another question. I was wondering, Moti, if you could go through the subgroup analyses, if there's anything that stood out or, that one group benefits more than another, or certain groups that we should think harder about or more, more aggressive about in our counseling, anything like that.
Yeah, I can bring up the that figure again in a second.
You mentioned something is going to be presented at SMFM, so please spoil away.
Oh, wait 1 second. Let me just do this share here. One, and then this is there. Is that? Do you see the figure?
Yes.
Okay, yeah. So this is again the subgroup analysis looking at chronic hypertension depending on when it was diagnosed, effective in those who are already receiving medication, but no difference in those who were newly diagnosed and diagnosed who had not been receiving medication previously. But again, underpowered in the scenario. It did look like it was clinical. It was significant in the non-Hispanic whites, however, not in the other groups of racial ethnic groups. Diabetes, regardless of whether you had it or not, effective and significant when being active with your treatment. Same with gestational age, whether it's less than 14 or greater than 14. And then BMI, the greater than 40, which we commonly encounter, is also greater, like unclear whether active treatment is effective because it was not
Morning.
powered. So really the newly diagnosed and the BMI greater than 40, sorry, are two patient populations that require further study, and SMFM had done that. And then if you look here, oral presentations, the plenary, the first one, treatment of mild chronic hypertension was tighter better. So this was an objective to evaluate the hypothesis that lowering maternal blood pressure to less than 130 over 80 compared to 1. So this is tighter control, not necessarily those who had stage 1 hypertension, had significantly were significantly lower in terms of the primary outcome. So they were suggesting even potentially targeting goal of less than 130 over 80 would be better in these patients, not necessarily less than 140 over 90.
Yeah, thanks. That's exactly what I wanted to highlight, I think, for everyone, is that this is not like the be all end all, and there's certain groups of people and patients that we can still be doing better.
So yeah, it's pretty exciting. A lot of secondary analyses from the CHAP trial are going to be presented because, interestingly enough, this trial, most of the time, like MFMU trials get presented at SMFM, but actually the CHAP trial was presented at the American Cardiology meeting, early in 2022 before it was published. So that's why now all the secondary analysis are going to be presented at SMFM. Thanks for the nice comments. Any other questions or comments? I think we're approaching 8 o'clock, so I appreciate everyone and thank you very much for joining.
Thank you, Moti. Wonderful lecture.
Great.
Incredible lecture, Moti. Thank you.